Well, hello everybody, and welcome to this second Biomch-V online biomechanics lecture. I'm Dan Bassett, and today with me we have Philip Rowe, who is our speaker.
Hi.
And yes, welcome, Philip. And just to give you a little bit of background on Professor Rowe, he came from the University of Birmingham with a Bachelor of Science in Mechanical Engineering and did his PhD at the University of Strathclyde and has had a fantastic career so far, and it's looking great for the future as well. As he's gone through doing his PhD and then various academic appointments at Queen Margaret University in Edinburgh, and ended up back at Strathclyde doing some excellent research that has helped elucidate the clinical outcomes of various musculoskeletal and neurological disorders, such as knee replacement surgery, hip replacement, hip fractures, back pain, hypermobility syndrome, patellofemoral pain, stroke, aging. Lots of really great work, which has led him to us today, where in all this experience, I'm actually very excited to hear what he has to say about it, as he's going to be speaking about visualization in biomechanics and movement studies. So, going to pass the word to Phil now, but just to let everybody know, due to the format we have here in this live web broadcast, go ahead and ask any question you have at any time, and at the end of the lecture, whenever there's a time for questions, I will pass the questions on to Phil, and we'll get some answers at that time. So, without any more tension on me, there you go, Phil.
Thanks very much, Daniel. So welcome to this webinar. As Daniel said, I've spent my career in biomechanics, partly in a bioengineering unit and partly in a rehabilitation school. So my outlook is somewhat different to a lot of academic modeling biomechanics, so hopefully I'm going to give you a bit of that flavour. So the outline of my talk is to begin with a bit of history of the biomedical engineering group here at the University of Strathclyde, and our relationship to the formation of Vicon. A bit of my history and my interest, some of the work that I've done in orthopedic assessment. That led me on to being interested in robotic arthroplasty surgery, which uses camera-based navigation in an operating theatre. And from that I saw some different ways that we could maybe do our traditional movement analysis in clinical practice. I then got a project which was called Envisage, which was about engineering visualizations in aging, and was basically about showing biomechanical data visually. And finally, I'm going to tell you some of the things we're currently doing and our links with Vicon and Motec ForceLink that are helping facilitate them. So I work at the University of Strathclyde in Glasgow in Scotland. We're founded by this man you can see here. There's a guy called John Anderson. He was quite a difficult man. He left Glasgow University in 17, and at the time he left, he sued both the Chancellor and the Rector of the university. So he obviously was a bit of an irascible guy. But he founded Strathclyde with the council in Glasgow as a place of useful learning, which was a direct dig at his former employers. But what that means is that the university has a very strong applied theme, and we see ourselves as a leading technological university doing things that are relevant to business, industry and clinical practice. This is the bioengineering unit, which was, as it says, founded in 1963, so over 50 years ago now. And it's had a continuing interest in biomechanics over the years. This was begun by the man who was my head of department when I arrived for my own PhD, Professor John Paul. And John was a remarkable man. He was a lecturer in mechanical engineering at Strathclyde, and he was approached by the professor of orthopedic surgery here in Glasgow to try and solve a problem. And the problem was they were trying to fix hip fractures with pins, as shown in the diagram, but the pins kept breaking and they couldn't understand why their pins weren't strong enough. And John said, well, no problem, that won't take me long, I'll have a look at that and come back to you. And 50 years later he was still researching and analysing hip replacements. So he underestimated the task a little. However, what he did was he took a technique, a medical technique from X-rays called stereophotogrammetry, where you sent two X-ray beams across the subject to plates on the far side of the wall, and from that you could triangulate where features were on the X-ray. So it gave a three-dimensional measure of objects in space from two perpendicular cameras. And John realized he couldn't use X-rays very easily, especially not for people in motion. So he used the technology of the day, which was a Cine 16mm Cine camera. I'm sure that some of the audience won't remember this device, but basically it had a hard film inside it that was mechanically driven through the lens and exposed, and then you took the film out of the camera and sent it off to Kodak usually, and 2 weeks later you got a developed film back. So John used two camera stands, the red dots, looking at a capture volume which is marked in green, and on the far side of those, the capture volume from the cameras, was a big calibration board that he could measure things against. So here's a picture of our lab in the early 60s, with the camera down here straight ahead. To the right there's a black calibration board that you can see there, some big curtains, and basically we're standing on the site of the force plates. So what John did was he took these cine films and he hand digitized each of the frames by projecting them up on a wall and measuring the position of each marker that he'd put on the body. And he did that obviously in the two planes, and then he calculated using trigonometry where the location of each dot must be. He then built a three-dimensional model of the load actions of the muscles within the body, having calculated the external joint. So here's an example of the lines of action of the various muscles at the hip. Now, what's remarkable about this for me, and his PhD was 63 to 67, is that as you can see, at the time, all he had was paper and pen. So every analysis frame that he did, he hand calculated and hand digitized. And we take it all for granted now, but it shows that the methods are still accessible. If you work out the maths, then you can still access the methods that are in biomechanics. And we tend to think that all the software we get is so complicated and fancy, but in fact the process underneath it is still capable of analysis. John's thesis is available. You can get it from the internet. It's actually, although he was a lecturer here in Strathclyde, he did his PhD with the University of Glasgow, and it's called Forces at the Human Hip Joint. This is the typical data that John produced in his 3-year period. So there are, I think, 10 males and 6 females, and a gait cycle for each one. And these are the calculated joint force as a ratio of the body weight. So 1 would be 1 body weight. He's also included a predecessor of his, Rydell, whose data was about the only published data prior to this on what the loadings on the hip joint were. And you can see Rydell predicted 1, 1.5, 2 body weights on the hip. And you might, if you're not biomechanically familiar, assume that there was about a body weight on the hip. Well, as you can see from John's data, in fact, there's somewhere between 2 and 4, maybe even more, body weights on the hip in males, and slightly less in females, but also there's a big range of variability, partly because of the methods, obviously, but partly because that's the nature of the human. So John was able to show that the reason why these pins were failing was because they were having to take at least twice the load that anyone expected. In the 1970s, the unit invested in a mainframe computer. This is a PDP-11 computer to help do the calculations. And then we got a disk drive. So when I arrived in 1983, this was the data storage and program storage mechanism. I think it was an 8 kilobyte disk. So the computing power was still very limited. The Cine cameras were improved. So this is a Cine 8 camera with a better lens, so that we didn't have to have quite such a long distance between the cameras and the force plates. At this point, I should acknowledge the contribution made by Professor David Winter, who was a kinesiology professor at the University of Waterloo in Canada. And David introduced the first TV camera to biomechanics. So here you can see his camera. It was a 1-camera system and worked in normal lighting conditions. So John Paul and his student Mike Jarrett took one of these cameras and adapted it with an infrared stroboscope on the front to operate in the infrared spectrum and to use reflective markers that we are common to us today. And here's an example of what that looks like for those of you who have never seen it before, which I imagine is very few. What I find fascinating about it, if you look at these, animations, is just how much quality of movement information you can see from a set of 11 moving dots. I'm sure you all recognize this as someone rising to stand and sitting down. I'm sure you could tell me where the markers are placed. You can also see the wobbles and balance control issues that are going on within the movement. And for me, as a biomechanist interested in clinical data, the challenge for us is to take that data and show it in ways that use the full quality of the movement capture that we've got there. And I don't think we've got anywhere near doing that as well as we should be able to. This is an example of the coarseness at the time of the retinas of the camera. So you can see in the picture at the bottom the pixelated appearance of a marker, and then at the top the analyzed location of that marker as representing as best it can the sphere that you see below. So you can see it was quite a crude process. Nowadays we have retinas with megapixel resolution, so we don't see this. At this point in the history, this company called Vicon was formed in Oxford as part of the Oxford Metrics group, and with some input from previous students at Strathclyde, they built a prototype system, and they actually built 3 systems, one for Oxford itself, one for Dundee, and one for Strathclyde. And Dundee were a kind of sister group to ourselves. And here is that early Vicon system with 4 of these cameras. The box in the middle is the controlling process, the processor. There's screens and a printer. Our system actually only had 3 cameras, and we had them set up in a similar way to our cine cameras had been, but with a 3rd camera on the other side now that we had the room, so that we could do both sides at the same time. And that's the point at which I entered the frame, if you like. This is me at the age of 12. I haven't, as you've seen, got any hair left now. And I was always interested in physics, maths and biology. And that was a combination that many of my school advisors didn't want me to study. They would have rather I did physics, chemistry and biology, or physics, maths and chemistry. But the combination of physics, maths and biology was one they didn't understand. But luckily for me, my biology and maths masters taught to each other, and they gave me a book by Leonardo da Vinci. You can see on the right. Laid out was mechanics, mathematics, physics, and human biology. And from that point on, I always wanted to be, sadly, I always wanted to be a bioengineer and a biomechanist. When I was appointed as a PhD student here at Strathclyde, my project was related to total hip replacement, which at the time was a very new procedure, which had been developed in the 70s by the man you can see on the screen. He's Sir John Charnley, the surgeon. In fact, his technician did a lot of the legwork, but but Charlie got the credit. And this operation involved cutting off the greater trochanter, opening up the hip joint, putting in the implant in the femur and the acetabulum and cementing them in, articulating the joint, and then at the time rewiring the greater trochanter back onto the rest of the femur. And you can see that in the X-ray on the left-hand side. And these were the first really successful hip replacements, low friction, and they survived. And I was asked to evaluate them and evaluate the mobility of the patients in Glasgow that were receiving them. And my predecessor, who was my clinical supervisor, a great man, unfortunately not with us anymore, Ian Kelly, he had studied a group of hip replacement patients at 6 months, and in his 2-year MD he had only studied 17 people. So he had 17 tests once, but done with what we would now understand as a £1 million gait lab, and you can see a picture of it here with cables going to the cameras on stands and so on. I, in my naivety as a research student, told him and the professor of orthopedic surgery and Professor Paul and my supervisor, who was Professor Nicol, that actually if we wanted to look at the outcome of joint replacement patients clinically, full biomechanics done in this way was not the way to do it. So a flexible electrical goniometer, which you can see in this picture, we used 4 of these mounted over the knees and hips. Sorry about that, I just got a message that my battery was low, so I've plugged in my PC. Yeah, so I used 4 of these on the hips and knees, some foot switches to tell me the places in the gait cycle, and some force transduced walking aids so that I could measure how much force the patient was putting through their walking aids for assistance. We managed to study in my PhD period with this system 65 total hip replacement patients, and at 4 points between pre-operatively and 1 year post-operatively. Here you can see the range of motion that they used at the hip over that period of time. And while their hip range of motion improves from pre-operatively, it was still significantly less than a normal age person, a normal person of the same age. When you looked at their walking speed, this increased and got closer to normal, but again was significantly reduced. And they were clearly achieving this walking speed by compensation for their lack of range of motion at their hip. Subsequently, I've gone on to look at knee replacements are more difficult to analyze. However, in my tale, I should tell you that at the end of my hip study, I made some recommendations about how hip replacement patients should benefit from better treatment. So as you saw in the X-ray previously, let me just go back to it. We used to cut off the greater trochanter to get the implant into position. And we also used to cut through the side of the hip in order to get access to the hip joint. And I showed, using full biomechanical analysis on a subgroup of my patients, that in fact this was due to the fact that they couldn't generate sufficient moment at the hip in the abduction plane to produce a normal stride length. And this was clearly because their muscles, their hip abductors, weren't strong enough, because they've been disrupted by this surgical procedure. So nowadays it's common to go in posterior laterally, so that you don't have to divide those. Likewise, we don't cut off the grade. So the surgery has improved. However, I made some recommendations about the fact that these people had weakened abductors from a long period of immobility, and that they maybe should get some better rehab designed to strengthen those muscles. And I couldn't find anybody to give that message to. The nurses and physios had been really helpful to me and my friend in undertaking the study, but there was no research forum in which to deliver this message. And as a result, I got a job in 1988 in a health school in Edinburgh, teaching biomechanics in a physiotherapy department and leading research development for the health school. That takes us back to the knee. And actually the knee is a much more difficult joint to repair and to rehabilitate. We have loadings going up to 10 times body weight through the knee. It has 3 joints in it rather than just one. A number of muscles that cross the joint, and it doesn't bend like a hinge, as everyone says, but bends, rotates, translates in a rather complicated manner. So people try to do knee replacement in the same kind of way as they've done hip replacement, but it's taken us 30 years to realize that we have to replace the knee in a much more anatomical way. So I use my goniometry technique to study knee replacement patients, and here you can see 2 of the commercial goniometers produced by Penny and Giles Biometrics, now Biometrics Limited of Wales, attached across the knee, again with foot switches and with a little data logger in a pouch on the front of the subject's chest, which recorded all the data. We sent these subjects on a walking tour of our hospital, in which they undertook a number of functional activities. So here you can see the activities: walking on the flat, which is the traditional one, up and down a slope, up and down stairs, in and out of a low chair, in and out of a standard height chair, and in and out of a bath, obviously without any water in it. Here you see what a typical range of motion for those activities looks like for a normal subject. So we've got gait as the first column on the left, then up and down a ramp, up and down stairs, in and out of a low chair, in and out of a standard chair, and in and out of the bath. And you can see that unlike the normal discharge criteria for hospital, which is a range of motion of about 90 degrees, you actually need somewhere between 110 and 120 degrees to do all of these activities other than the walking ones, and that the bath, actually, if you get into the bath normally, 5 degrees of motion. When we tested our preoperative knee replacement patients, they showed a plateau at about 85 to 90 degrees of motion. So they were clearly affected by their osteoarthritis. However, when we compared them to our normal data set at pre-op, 4 months, and about 2 years post-op, for every point in time and for every function, our knee replacement patients were significantly reduced in range of motion compared to normal. Even more disturbing was that at 4 months, 6 of the functional tasks actually showed a deficit. And you might say, okay, that's not too bad. At this point, they were probably still using some walking aids. However, when we retested them at 2 years, those 6 functions had only got back to the level of the preoperative function of the patients, and only 3 of the tasks, shown in green, had improved. So level walking, slope ascent, and slope descent, and then only by 3 or 4 degrees of range of motion. So functional range of motion is only about 70% of age-matched normal subjects 2 years post-op. We've published studies where we have retested them up to 7 years, and that situation doesn't improve. We've also shown that they were 16% less active than age-matched normal subjects, and in a population that is already often overweight because of the inactivity prior to surgery, that is a significant health risk. Their quality of life showed a reduction that was correlated to their lack of range of motion, and we've also compared unicompartmental knee arthroplasty with total knee arthroplasty and shown that actually UKA, a single UKA, gives you a better outcome than a total knee arthroplasty if you're suitable for UKA only. So the future in orthopedics is smaller implants that do less disruption to the mechanical structures of the knee. Surgery, so removing less bone, hopefully, and doing less damage to the ligaments. We also, at the moment, fit the alignment of the device to what is the average knee, and yet everybody's knee is variable. So in the future we need to have criteria for aligning the implants based on the person's knee, and ultimately it would be best if we had personalized implants that fitted your own anatomy, not the average anatomy of the average knee. What this implies is that there's an increasing surgical challenge necessary to put in the implants in a correct alignment. There's been evidence in the literature that a 3-degree error is sufficient to cause early loosening and wear of the implants. So it's a hard task for an orthopedic surgeon even to put in a standard implant within those clinical guidelines. As a result, I then got interested in computer-assisted orthopedic surgery, and I came back from my time in a rehabilitation school back to Strathclyde, to the biomedical engineering department as a professor of rehabilitation, and I was able to pursue this with some of the leading orthopedic companies, particularly Mako Surgical, now part of the Stryker Group, and Blue Belt, who also make a robotic system. So for those of you who haven't seen it, what you do is you get a preoperative medical image of the joint. Usually that's MRI or CT. You then segment that image so that you can plan the operation in the computer, And then you go into theatre with a pre-planned position of the implants. In the theatre, you use a motion capture system to help you navigate where you are in 3D space and where you are relative to the anatomy of the subject on the table. And then you can use robotic surgery, which is effectively an industrial milling machine, to cut the bone. So here you see that miller. It looks like a very similar to a dental drill, except it's got a 6mm burr on the end of it. And this is the Mako robot. So this has a 6 degrees of freedom haptic arm. So it knows where it is and where the end of the burr is, and it can stop you moving the arm as well as being free and allowing the arm to move as you push it about. This is the complete system. So you can see on the robot to the left hand side at the front there's a cluster of markers, an asymmetrical marker cluster system. Then in the middle we have a navigation stand with 2 cameras in the black windows doing the in-theatre navigation. And then on the right we have a control computer and screen for the operator who looks after the visual displays that are displayed on the middle screen underneath the TV cameras. So the surgeon who's scrubbed up operates the robotic arm, and then the technician who's assisting him, who isn't scrubbed up, operates the computer and the software that's needed. So it's a rather poor picture, but here you can see the system in operation. So we've got the big cluster at the top right hand side, which is telling us where the robot body is. We've then got a cluster of markers below that, which is on some bone pins embedded into the patient's femur. So we've got a rigid connection to the bone. And then underneath the surgeon's hands, you might also be able to see a cluster of markers, which is embedded in the tibia using some bone pins. What the surgeon will do is they will open up the knee and expose the bones of the patient, and you can see them doing that in this picture. And then they will use a probe with markers on it, which is also tracked and navigated, to produce a matrix of dots that represent the surface of anatomy of the joint surfaces. The system then fits that mesh to the pre-obtained CT or MRI scan and registers the two together. And at that point you then know where the joint surfaces are in 3D space, and you can track them. So what the surgeon sees is a visualization like this, where the green area represents the bits of bone to the depth of cut that's indicated. Then the robotic arm will resist his movement and stop him going past the agreed bone removal plan. If he tries to push past that haptic wall, the system will shut down. So we have carried out the first independent trial of this technology as a randomized controlled trial with my colleagues in the Glasgow Royal Infirmary. And here you can see a graph of the outcome of 2 groups of approximately 50 one got a conventional Oxford unicompartmental knee arthroplasty, which is the ones in blue, and one got a robotic Mako system, which is the group in red. And the dotted lines are the 95% confidence interval for each group. If you look at the left-hand side, you can see that during stance phase, the Mako red group got significantly more knee flexion during stance than did the Oxford unis. And this for us is a significant and clinically relevant difference. This is the weight-bearing phase of gait, and that change of approximately 5 degrees represents a valuable clinical difference between the two groups. So we can now make implants that are suitable. We can plan and execute surgery with speed and precision. We're going into the area of computer-aided design and manufacture, which will allow rapid and bespoke implants, and is already allowing the tools, the implantable guides, to be bespoke for each patient. And it also presents in the future the possibility for individualized surgery, because we can now control the position of the implants very accurately to a sub-millimetric level. Okay, and at that point, my predecessor and my own supervisor, who had been our head of department, Professor Nicol, or Sandy Nicol, he retired, and I inherited the responsibility for the entire biomechanics, clinical and sports biomechanics group. And I thought about it, and I thought, well, you know, where should we be going with biomechanics? We actually, in our biomedical engineering, rehabilitation engineering group, have 6 areas of special interest: clinical biomechanics, sports biomechanics, robotics, neuroprosthetics, which is combining electrical signals from the body with prosthetics or orthotics for that matter, prosthetics and orthotics itself, and tissue mechanics. And we are a centre of excellence in rehabilitation research, recognised by the Scottish Government. And at the time, I was helped by Vicon to kind of return to the fold of 3D biomechanics, and I realised that the technology had moved on significantly. So this is an animation studio. Our animation colleagues are putting up tens, if not hundreds, of cameras. They're also marking up people and doing multiple acting with multiple marked people. So the use of multiple markers is not a problem to them. When you look into their industry, they also don't spend a lot of time calibrating or setting up their processes, and they're able to visualize things in real time. My experience from the orthopedic world was that you could put a motion capture system in an operating theatre, and it would work, and it would work very efficiently. So we used asymmetric marker clusters, as you've seen, and they were automatically recognized by the system and labeled. There was no way an orthopedic surgeon was going to take the time to label individual markers. And that got me thinking. And I looked at some of the engineering applications that were going on in our sector. And this is a hyperbolic plane for space training, and in this scenario you get about 30 seconds of weightless flight before you have to pull up and climb again. So you get a very limited opportunity to get the data that you want. And you can see they were using Vicon cameras and markers to look at the movement of their astronauts in space. And I thought, well, why was I wrong when I decided many years ago that 3D motion capture couldn't be used clinically, that it was too complicated and too time costing? The quality of our cameras, so this is a T-series camera from Vicon, has improved incredibly, where we now have megapixel retinas for our cameras. And we also have now cheaper versions of these cameras which have the quality that far exceeds those that we started off with 30 years ago in the 1970s. These systems are really easy to put together and install. They're almost plug and play with internet cables connecting them, and you can run them actually off a laptop. So in reality, we've gone from this multi-million-pound, time-consuming scenario to something where you could have a clinical facility using motion capture for £10,000 to £20,000. Another thought that I had while I was in this phase of my career was that I had spent a long time, over 15 years, teaching biomechanics to physios, OTs, clinicians, podiatrists, etc. And they weren't too keen on maths or tables and charts. I'd also done a project where we took biomechanical data of older adults and we gave it to design engineers so that they could design to include the elderly. And to our surprise, they also didn't like tables and charts. They were designers and they were much more visual. So at that point I decided that as much as I could, I would ban tables and graphs and charts as a way of showing biomechanical data. And that led us to the Envisage project, which I undertook with two local universities in Glasgow, the School of Art and Design and Glasgow Caledonian University, which has the health school. And the idea of Envisage was that we would use biomechanical data to communicate motion capture principles and clinical data, but in a visual way. So the full title was Promoting Independence by Involving Users in Rehabilitation through Dynamic Visualization of Biomechanical Data. Our hypothesis was that if we did this, that the visualization of relevant biomechanical data to these users, which included the participants, their carers, the therapists and the clinicians, in other words, everybody who could help them get better, would enhance their understanding of and motivation to rehabilitation, and hence produce a better outcome from rehabilitation. And at the top of the slide you can see an animation of someone rising to stand and sitting down, where we've coloured the joints according to the physical demand being placed on them by the functional task. In Envisage we had five work packages where we were going to build a visualization package for each client group and then assess it. So we had people who fell at home, knee replacement patients, stroke patients undergoing upper limb rehabilitation, stroke patients undergoing lower limb rehabilitation, and stroke patients undergoing lower limb rehabilitation who were using a tuned AFO, ankle foot orthosis. So for us, this represented a range of technological challenge. We had a range of settings from home to hospital, and obviously we had a range of patient severity. So the fallers fell, but they had not fractured, they didn't have any physical injury, all the way through to the stroke patients who obviously had, by the time they were needing an AFO, complex neurological and biomechanical damage. Each work package did a development phase where we developed the visualization package with users, including both patients and clinicians. We then undertook a feasibility RCT, a pilot RCT, to see if the intervention that we'd planned was both feasible and whether it had the potential to have an effect. And then we evaluated the whole project both quantitatively and qualitatively. So here you can see one of our user workshops with our research fellow Bruce Carse discussing how the visualization that you can see on the screen behind him was interpreted. From a biomechanical perspective, the visualization is showing the moments being generated at the knee and hip and whether they're correct or not. So at the knee we have 4 green bars indicating that that is normal, but at the hip you can see they had 2 green bars and 2 orange bars showing that while the moment was on the correct side of the hip, or the ground reaction force passed behind the hip, it wasn't far enough away from the hip to be normal. So in other words, the moment there was reduced. Obviously if it reduced still further, they would get 4 orange bars and then they would start to get red bars, and if the ground reaction force passed to the wrong side of the hip entirely, then they would get 4 red bars. We also did some exergaming, or what we would prefer to call it, which is purposeful gaming. In other words, games that have a rehabilitation purpose rather than just an exercise purpose. This is one of the upper limb stroke training games that the users were asked to try. We found out that the older adults were highly competitive, and they liked computer games. They just didn't like shooting things or each other. So with this game, for example, they were dying to have another go. They wanted us to carry on the workshop so they could beat their previous score, and so on. We also looked at ways of giving them quantitative feedback. So here you can see an example of giving feedback on their step length. We practiced what the scenario might look like in their home. So this lady's wearing some IMU boxes which are measuring her joint movements and getting on the screen a visualization of her movement as she conducts it. And this is the system we used in the home. We could show people their movement as they were doing them, and we could count the number of times they'd done it, and we could send that information to their treating therapist. We could also show them how they were moving and get them to do it in time with a movement guide as an avatar on the other side of the screen. The patients invented their own game, which was a trainer for sit to stand, and here you can see an image of it. So when you rose to stand, the pigeon would rise up, and when you sat down, the pigeon would sit down. And the idea was that you had to miss the fruit and catch the flies that came out of the back of the lorry. But if you did that at the wrong speed, then the amount of fruit would increase. So it encouraged you not only to do the movement, but to do it at the right pace so that you got the full training effect. Here you see an animation indicating range of flexion at the hip being generated, and the green zone indicates where we want the patient to be able to get to. Here's an example of using the animations in the hospital. On the left hand side you can see a small OptiTrack motion capture system. So there are 2 cameras on a pole in that corner, and there were 6 other cameras around the room on 3 other poles. We also have a video projector on a box projecting at the wall, and at the bottom of the screen you can see the computer that's generating the imagery. Here's an example of an animation for the upper limb. And when we set out, we were quite worried that patients would not be able to work with dissembled bodies. So there's no head, and there's no other arm, there's no pelvis or legs in this example. But actually the patients found this quite understandable. We could also show them how they were moving and gait data in the background at the same time. So here's an example of the ground reaction force, and the little blue dots are showing where each leg is on that movement profile. We could show them the asymmetry of their current movement, so you can see the large difference in step length for this hemiplegic patient, and we could compare them to a normal person doing the same task. So here's an example of the quality of the animations. They are quite simple, and that was deliberate because we wanted the subjects to focus on the movement and not on their appearance or anything else in the background. So they're deliberately quite simple avatars. And obviously the data is fully three-dimensional, so we could show them views that they couldn't see in other ways. This was one that actually helped a lot of people understand how they were moving their arm to reach. Here's an example of that for a hemiplegic patient, and I remember this lady very well because she hadn't realized she was moving like this until we showed it to her, and when we did, it upset her quite a lot. So you can see her reaching forwards for the virtual object, but as she does so, she moves her trunk and her shoulder way far forwards compared to what a normal person would do. However, once she'd recovered from this initial shock at her level of disability, she then started using the animations to put the movement right, and within a half an hour of that practice, she was performing the task much more normally. Here's an example of a gait animation. And these would be available, well, they would be played in real time, but realistically the patient couldn't see that, so they could be played back straight away afterwards, and you can see we could play them back in slow motion. We could pause it at any particular place, and we could rotate the view just like you can in a normal set of motion analysis capture software. This is an example of a comparison between a normal person in the background and a hemiplegic patient in the front, and you can see when they weight bear on their hemiplegic leg, they get hyperextension of the knee and a backward thrust at their hip. Let me just show you that again. Oops. So if you look at their knee, when they weight bear on their knee at the initial phase, the knee gets pushed into hyperextension and their hip gets pushed backwards. So the ground reaction force is not doing them a favour at all at that point. And that's where our AFO fitting and tuning project came in, because in those circumstances we would then give one of the stroke patients the opportunity to have an AFO which would help deal with that problem. Here you see a video of the system in operation in an ordinary clinic room in a community hospital. In Strathclyde we use these rigid cluster markers because they're much quicker to put on, and all you need to do is strap them around the person's clothing. Now obviously they're at risk of some soft tissue movement, but actually when we're doing this kind of visual feedback, we can afford to be slightly less worried about the errors than you might do when you're doing a classic gait analysis. So in the Envisage project, of the 5 small-scale studies that we did, 4 of them showed a positive outcome for one or more of the primary outcome measures, and the 5th one was positive but not statistically significant. And as you might expect, that was the most complicated one, which was the stroke patients with the AFOs. I've done a number of randomized controlled trials in my career, and it was very unusual for a small scale study to produce a positive outcome. And for 4 of the 5 of them to prove positive shows that, to us, that there's a significant clinical benefit being developed by the visualizations. So we concluded that when you took it as a whole, the experience was highly positive both for the patients, the clinicians, and, if you like, for the research outcome, and it was worthy that we continue to develop this field. And that was a point we reached about 18 months ago, at which point we discovered a company called Motec Medical, who were a relatively new company who produced a high-end rehabilitation platform initially designed for military veterans. And they were linked up to Vicon and were using Vicon cameras. Now, as I mentioned at the beginning, much of our clinical development was based on those early camera systems with their limited quantification ability. So they were built for big markers and a few of them, not very many. And that's not necessarily the best combination we should be using anymore. And obviously, if you're going to do the head as well, you get a lot of markers to stick on the body. The model I just showed you is a plug-in gate produced by Vicon, but it's been around for 25 years. It's very good because there are reporting tools built into the Vicon software, and you can print out gait reports and so on. And a lot of the clinical sites in the UK certainly make use of this technology and have records going back over 20 years. So it's done a good job, but it's not necessarily optimum for visualization and the future. Here you can see the full plug-in gate marker system. Strathclyde in the early 20s moved on to a cluster marker based system, and there is some research to show that this is probably more accurate. So we typically used 4 clusters on a rigid marker, and we embedded our own axis set in that, and then we related that axis set to the anatomical reference frame of each body segment. So this would be our typical setup. We would have clusters on the shank and the thigh, either a band or a cluster on the rear of the pelvis, and those clusters we would leave on the whole time. We would also have markers on the feet that generally stayed on the whole time, and then we would add some extra markers to mark the anatomy of the subject. So I've shown them in green. The medial side of the ankle, the lateral medial side of the knee, and the iliac spines, the four iliac spines of the pelvis. And we would take a standing frame, or a number of standing frames of the person, and use that to relate the cluster to the anatomical, and then we would remove all the single green markers. It reduces the number of markers that you have to put on, but also it takes away some of the markers that are most vulnerable, either to being knocked off or to moving around due to skin movement. One of the main attractions, apart from the system itself, of the Motec medical system was the software, which is object-orientated drag and drop and link software. In our original Envisage project, we had written all the animations by hand as lines of code, but this software offered us the opportunity to produce applications much more rapidly with these predefined modules. It also allows you to write your own script, so you can script in Lua, which is an easy computing language to learn, and so we scripted in our own marker system and then animated things using the dFlow software. Motec itself have their own body marker system called Human Body Model, and you can see it here. And this is a remarkable piece of software, really, in that it goes all the way from the markers through the reconstruction of segments, and then overlays on that a muscle and skeletal model which estimates muscle forces based on the kinematics and kinetics being streamed to it, and it does all of that in real time. So here's our Motec system. This is at the University of Strathclyde. We've got the lights turned on at the moment so that you can see what's going on. We have a 180-degree immersive screen. We have a Vicon 12-camera Bonita system, which is picking up the markers on the subject. The subject standing on a moving platform which has 6 degrees of freedom, and on that is mounted a dual belt treadmill with 6 degrees of force measurement of forces and moments, force plates underneath the belts. So each belt is individually controlled and has its own 2.5 meter long force plate underneath it. There's also a safety structure and a safety harness, so that the patient can't fall off the moving motion base. They have their own stop signal, and one of the real benefits of this system is that you can use the motion markers to drive the treadmill. So I'm not usually an advocate of treadmills for biomechanics, but actually normal treadmills, it's because your feet get taken away from underneath you and it doesn't feel very normal, and likewise the kinematics and kinetics are not normal. However, with this system, When you get on the treadmill will be stationary, and then as you take a step forwards, the markers will move, the system will start up the belts, and it'll do that individually for each leg. So it feels much more like normal walking. And the motor control of the belts is sufficiently good to speed up and slow down within a gait cycle. So when you walk on it, it doesn't feel like a normal treadmill. It feels much more like normal walking. And because you have an immersive environment around you, that enhances that feeling. And there's information in the motor learning literature that repetitive practice and environmental enrichment or immersion helps the brain to reprogram itself after a neurological or musculoskeletal problem. As I said, this was developed for military amputees and other people recovering in a veteran context. Here you can see, as my colleague Andy moves around, the markers in the background are moving around in real time and are being visualized in real time. Here we are with the lights down. And you can see the human body model, quite similar to the plug-in gait model with single markers. Here you can see the operator's now turned on the skeletal model, and it's now generating that skeletal model in real time. And you can see that as the muscles are predicted to have force in them, they go from being an orangey colour to being green. Now obviously you're recording all of this and analysing it in real time. You can give visual feedback to the gastrocs on the left hand side to an orange ball on the left, and the gastrocs on the right hand side to the orange ball, the blue ball on the right hand side. And he's made the size of the ball vary depending on the amount of force predicted in the muscle. So you can see, and there you can see the treadmill going into moving mode. But as he moves now, the force in his gastrocs is represented by the size of the balls, and obviously you can encourage a patient who's not actively pushing off to push off more actively with this kind of feedback. Finally, this is an example of the kind of visualization. The kind of visualization that is possible. This is a stroke patient walking with my colleague Andy Kerr, and they're walking through a wood, and it does feel very normal and natural when you're there, surprisingly immersive. You can see that the wood is about to turn, and when that happens, the path turns, the platform will turn, and further on there's a bank, and when they get to the bank, the platform will heave up and heave down again. So you can get quite realistic training scenarios. As I said earlier on, one of the big appeals for us was the D-Flow software, and this is the construction pane for that. And basically you just drag and drop these icons onto them. So there's one already set up for motion capture, and you can drag that in and just click on the Vicon capture tab. Likewise, you can control the platform. You can add in fidgets of A to D converter and so on. But the best part of it is that there's a whole series of visual tools that can help you then make an animation. You can put different visual flows in the background, and then you can attach various objects to the data that you want to highlight. And this is what a typical script looks like. This is the script that we wrote to do our lower limb model, so that's in the middle. You can see the motion capture module over here linked by wires to our model. There are bits for feedback on squatting, for producing targets for the subject to attempt to reach, and up here there are text messages that go up on the screen to tell them to start or to stop and so on. So currently we're developing 16 applications for use in rehabilitation. We think that the full system that you've seen has benefit and is a really good test platform for these kind of applications. But actually, we think what is most needed in rehabilitation is cut down versions where you might have a treadmill, an 8-camera Vicon system, and a large flatbed TV screen to give the feedback. So we're developing a whole series of applications to see if we can use this kind of application for evaluation and for training in rehabilitation. So some of the areas we're working in, as you've seen, ankle-foot orthosis tuning, the idea that we might be able to do dynamic prosthetic alignment and speed up the process of aligning a prosthesis. We're still developing applications for upper and lower limb stroke. We are developing a package for falls and fallers, an orthopedic package for joint replacement exercises post arthroplasty. For colleagues who run the back pain and lifting and handling services, and showing back animations, CP Kids and CP Kids assessment and surgery, as well as, if you like, purposeful games that help them gain motor control. And finally, our latest area of interest is in autism, which shows signs of having a motor component to its diagnosis. So that's the end of my presentation. Finally, can I say that if you've been interested at all by this presentation, you'll get much more to see at the 25th Congress of the International Society of Biomechanics, which is being held in Glasgow, hosted by our department, from the 12th to the 16th of July of this year, 2015. And I look forward to seeing you there. Thank you.
Well, thank you very much, Philip. It was a great talk and very illuminating, where I think I speak on behalf of most biomechanists. We're very used to thinking in terms of graphs and giving specific numerical feedback to subjects and patients that we're working with, whether it be sports biomechanics or not, where you're suggesting that you've had much more success actually showing them the actual models in real time and helping them. Can you elaborate a little bit more on how much success you've seen with that and how you've seen the progress of therapy?
Yeah, so but just to point out that although we're visualizing the data, at the behind all of that is the data. So you can also show it as graphs and tables, but not start there. So, for example, we have a situation where you can click on a joint and you'll get the gait graph for that joint, and you can do the same for another joint and see how they compare to each other. So it's not that our typical biomechanical things aren't useful. I think it's not the way to start and engage people. And we did of 84 older adults in Glasgow, who went from 65 to 95. We had to give a user feedback of what we'd found out based on the grant. The grant conditions were that we gave feedback to the participants. So we organised a workshop day, and we got them all in with their therapists, and we showed them these animations. And to our surprise, in a way, at the time, they were able to interpret them quite happily without any biomechanics present. So they would be saying, "Oh, that's how I get out of a chair. Yeah, I've got a bad knee, and I tend to favour the other one, and I don't press so hard on my that arm as I get out." And they were able, and the therapist would be saying, "Yeah, and that's because this, and maybe you should try and do that." And it was very noticeable that we could facilitate those conversations, but not necessarily have to be in them. And I guess my education, the side of me that spent a long time educating therapists, knows that they have the ability to interpret the mechanics, but it's a real hard push for them to turn them into bioengineers. So, I feel that the animations can get us to a point where we can all communicate. Another example is the trials that we did, where we had groups of 10 in each arm of the trial, sometimes less, and yet we still found a significant change between the two groups. And that's really quite a strong clinical effect. The patients loved it. I think it provoked some strong reactions in them when they realised how disabled they looked, and how disabled their movement was, and they responded positively to that, trying to put it right. In my own experience, I like skiing, and as you can see, I'm not exactly slim, and I used to think I looked like a downhill champion until I got videoed going downhill on the slope and saw how I actually looked and what my actual body posture was. And we use those techniques all the time in sports biomechanics, and even now on the high street you can get tested for your golf swing or your running shoe style, and we ought to be able to do that for our patients in care who could, the fundamental principle of motor learning is that you get knowledge of performance and knowledge of the result. So I think if we did this more, our colleagues in the clinical professions would understand biomechanics better, and probably would end up using graphs and tables for reporting and for research. But at the moment, we're making them do all the hard work, and life has become very, very visual for everybody. So, I think we should all band together and do this. Try it.
But that sounds good. I think I'll definitely be applying a lot of that in my own work as well. And we have one more question. How much of a bump in the efficiency of training have you seen between now you're talking about basically showing them video so they have some feedback, but it's more discussed, and how much better is it when that's live as you were showing the Motec system. This is live biofeedback. Do you see this being effectively that much better, or if the difference in therapy is small?
Well, like I say, I think the changes are large. I'm not saying that I think that every therapy session should involve visualization, but if you look at how elite athletes are assisted, they'll get regular feedback on their performance. If there are areas of the performance that they're struggling with, I know if they're a sprinter, then they'll be shown how they exit the sprinting blocks, and they'll do it over and over again until they're doing it in the most efficient way. So, and then they go off and practice. And I think what we should be doing is helping the person understand what would improve their movement, and then letting them go off and practice, and then giving them another evaluation, and off they go again. And that's the kind of programs that we're trying to put in place. I also think that the technology is at a stage where it shouldn't require a bioengineer or a biomechanist to operate the system. You know, it doesn't require that in an operating theatre, and I can't think of a more high-pressured situation. The animators do it for themselves. So one of the things we as a group are trying to do is make it so that all the user has to do is turn on the system, put some kind of calibrated object in the field of view to check that the system's still calibrated. It'll probably be permanently mounted, and then use it, and use it by clicking on a button that says visualize or record. You know, we ought to be providing that level of usability to our community. In fact, what's happening is that the software gets more and more complicated, and that's more and more a barrier to anybody else than a biomechanics expert using. So I actually feel we're going in the wrong direction. And we now have motion capture systems that are cheap enough to be affordable in clinical directions. So I'd say over the last year we've produced a cluster of 8 clinical motion capture systems in Glasgow alone. So I think there's a real desire for it within the clinical practice. We just have to make it accessible for them, and accept that we give up ownership of the data capture process, not of the whole thing, but of the data capture process. They'll still need some help to interpret it, and there aren't enough of us as it is. Now, there's a much bigger demand out there than we're delivering.
Well, thank you very much. I really appreciate your feedback, and the direction of biomechanics that you're envisioning, I think, should be an example to us all, and how we can better communicate with the medical and physio worlds. Really appreciate your time and for supporting this Biomch-V initiative.
Thank you very much.
And thank you everybody for watching, and we'll see you at the next Biomch-V online biomechanics lecture. Bye.